This seminar is for educational purposes only. It is not a substitute for professional medical advice or treatment. Consult with your medical provider for medical advice or treatment. Although the presenters try to keep the information in this seminar as accurate and timely as possible, the speakers and Mather Hospital assume no duty to ensure the seminar is error-free. The speakers and Mather Hospital are not responsible or liable for any claim, loss, or damage resulting from you viewing this seminar.
Good afternoon, and thank you for joining us today for our HealthyU webinar series. Today's webinar is focusing on mental health, depression, and suicide awareness. At any time during the presentation, please feel free to enter any questions you may have using the Q&A feature at the bottom of your screen. We'll answer as many questions as we can within the time allotted once the presentation concludes, and your questions will remain anonymous as always. Today's presenters are Dr. Jenna Taglienti, Dr. Megan Acito, and Dr. Joanna Stanchek. Dr. Taglienti graduated from State University of New York at Buffalo Medical School and completed her psychiatry residency at State University of New York at Stony Brook, where she also served as chief resident. Dr. Taglienti currently serves as program director for the psychiatry residency program and medical director of the mental health clinic. She is also an assistant professor at Zucker Hofstra School of Medicine. A board certified in adult psychiatry, Dr. Taglienti has been at Mather Hospital since 2016 and has a special interest in teaching and enhancing resident wellness. Dr. Acito is a New Jersey native and received her medical degree from Lake Erie College of Osteopathic Medicine. She is currently in the third year of her psychiatry residency at Mather and has a special focus on outpatient community psychiatry. Dr. Acito is also the junior academic chief for her class. Dr. Stanchek comes to Mather Hospital after completing medical school at the American College of Antigua. Originally from Poland, she is currently in her fourth year of her psychiatry residency at Mather and is the administrative chief of her class. She has a special interest in general psychology. You guys can go ahead and get us started.
Thank you. So I'm Dr. Acito Inez. Like was stated, I'm one of the third year psychiatry residents here at Mather.
Hello, and I'm Dr. Stanchak. I'm one of the fourth year psychiatry residents here at Mather.
I'm Dr. Taglienti, the psychiatry residency program director.
So we're excited to talk to you all about, a really important topic today. That's depression and suicide. So this is, kind of an outline of what we're going to be going through today. So we're going to start by talking about depression. And we hope that, by the end, you all have a good understanding about, what is depression? How do we as psychiatrists diagnose depression? Some statistics about depression, how we go about treating it. And then we're also going to touch on suicide, and we'll leave some time for questions at the end. So to start off, what is depression? So it is, a common and serious illness that can really negatively affect how you feel. So the symptoms do vary from person to person, and they can range from mild to severe, but we do have some criteria for, kind of diagnosing depression. So some of the symptoms that you may find if you are depressed would be feelings of sadness or low mood, loss of interest or pleasure in activities that you previously would have enjoyed, some changes in appetites that could be increase or decrease in appetite, and then you could have insomnia or difficulty sleeping, or you could have the other end, which would be hypersomnia or sleeping more than usual, which kind of goes along with the next symptom, which would be loss of energy or fatigue. And then we can also see some restlessness, or on the other hand, slowed movements or speech. And these would be observable by others. So people might tell you, like, oh, you seem really restless lately, or, you're doing things slower than usual. So they might be able to notice that. Other symptoms could be feeling guilty or worthless, also difficulty concentrating or difficulty with making decisions that normally you might be able to, make decisions normally, but then you might just kind of feel stuck. And then the last symptom would be thoughts of death or suicide. So as psychiatrists, what we're looking at is, can we, when someone's coming in with these kind of symptoms, do they meet criteria for what we call major depressive disorder? So how do we diagnose major depressive disorder? So the symptoms that I talked about on the last slide, they would have to last for at least 2 weeks. And as I was kind of talking about, we would be looking for a change in your previous functioning. So if previously you were able to concentrate really well, you were sleeping normally, and had normal appetite, and then all of a sudden or over time, you're developing these symptoms of decreased appetite, difficulty sleeping, then that would represent a change in functioning. And then you have to also have at least 5 of the symptoms that I mentioned. And these symptoms can't be due to another medical condition or due to substance use, which I'll talk a little bit about later. So these are some statistics about depression. So, depression can affect, about 1 in 15 adults, which would be about almost 7% of adults in any given year. And about 1 in 6 people will experience depression at some point in their life. Young adults are 3 times more likely to have depression than individuals over 60. And more women than men have major depressive disorder that starts in the early teens. And the chance that women will have the disorder like during their lifetime is actually 1.5 to 3 times higher than men. There's also a high degree of heritability. So if a first degree relative, like your parents or your siblings have depression, there's about a 40% chance that you might also experience depression. So here are some risk factors. So one would be biochemistry. So this could involve levels of serotonin or norepinephrine in your brain and your body. And this is kind of, an emerging field where we are, looking more and more into what biochemically is causing depression. And that this is kind of where our medications try to target the depression. And like I had said, genetics also can play a big role, as well as somebody's temperament. So, if somebody already has low self-esteem, a low attitude, poor stress tolerance, then they may be more at risk for depression. And this is actually what we try to target in therapy. So like Dr. Stanchak will talk about, in therapy, we are often trying to change someone's outlook or automatic thoughts about different situations in life. So we're trying to work on that temperament. And then also environment. So if somebody has history of neglect, low income, abuse, or violence, this can also contribute to depression. So Dr. Stanchak's going to talk about how we treat depression.
Okay, so just a little bit about the treatment. So out of all the mental disorders, major depressive disorder is one of the most treatable. So that's amazing news. Treatment is possible and it is effective. Typically, when you come into a doctor's office or a psychiatrist's office, they will do a psychiatric evaluation to assess for symptoms, and not only symptoms, just your social life, medical. They do a very intense evaluation, and sometimes it can last like an hour just to find out all this information. We may also ask for blood work just to rule out any organic causes. Maybe someone has hypertension, and maybe someone has thyroid issue, maybe vitamin deficiencies. So we really try to assess and make sure if we diagnose you with major depressive disorder, there's nothing naturally that's going on in your body that may be contributing to the symptoms. And treatment is twofold. So if we go into the next slide. So first is psychotherapy. And the way I like to describe treatment for my patients is it's kind of like you have a house and you have to cross a river. And this is an analogy that I got from one of the social workers, which I thought was like an amazing thing to use to kind of provide a little bit more insight into the treatment. But say you have a river and your house is on the other side, and the river has really heavy currents and you have to get there some way, right? So the one thing is the current. Medications take the current away. Okay, so it makes it a little bit easier, right, to swim. And that's the therapy. The therapy is the actual act of getting to that house. So as I say, and as we've all seen, I guess, in the psychiatric community, is not only is medications, you know, an important part, as well as therapy. So psychotherapy or talk therapy, this is pretty much done by a psychologist or a social worker. We sometimes, as psychiatrists, do also perform like talk therapy. But, you know, in the realm of things, usually it's by like a psychologist. So there's different types of therapy. So one is an interpersonal psychotherapy, and that's just enhancing the relationships that are around you, your social supports, seeing, you know, perhaps why there are issues with every interaction you may have, and that may be a contributing factor to depression. Supportive psychotherapy, problem-solving skills. How can I look at this situation and change my view about it? And usually, you know, the therapist or social worker will work with, you know, trying to help you maneuver, figuring out a problem you may have. Next is CBT, and it's actually found to be very effective in treating depression, and it really focuses on the problem and solving things in the present. So really looking at like the ABC. So it's looking at it, assessing a situation, looking at the thoughts that come out of the situation that leads to the behavior and the emotions. And once we're able to kind of understand the thought, we're able to really try to develop that alternative thought that doesn't lead into this reaction of emotions and behavior. So it's a really great way of looking at situations for what they are during that moment. Family or couples therapy, as well as group therapy. So group therapy is really great because you're able to be with people that are going through something similar to you. And sometimes something that someone else says may resonate with you. And that was just the way something was phrased, that the thought that was given, that you really understand, it really makes an impact. And then that's why I think group therapy is very great in terms of treatment. Medications. So as Dr. Esito was saying earlier, medications have a role of adjusting that chemical imbalance, whether it's serotonin or norepinephrine. And that's why antidepressants are utilized. And this is how SSRIs, SNRIs are created, and you know, monoamine oxidase inhibitors, tricyclics. So medications, the way, you know, when we do a psychiatric evaluation, we really, you know, try to gather history a little bit of, you know, are there any type of side effects a patient already like has, or like maybe they have like lack of sleep. Maybe they have a lack of appetite. Maybe they're not really that great with taking medications. And we take that into account when prescribing any type of medications. And we really try to listen to hear what the patient is telling us in terms of what their fears are of potential side effects, and really try to educate in terms of the risks and benefits of the medications that we give. Some of the side effects are typically waking, nausea, diarrhea, fatigue, as well as a loss of sexual desire. And if you find that, you know, some of these side effects may go on away on their own, and we sometimes call them like nuanced, and we just ask the patient to see if they could tolerate it for a little bit. But if they're unable to because of the side effects, it's important, like very important, to let your provider know, because sometimes some of the medications that we do prescribe, you can't just discontinue it cold turkey. Sometimes you do require a step-by-step approach of taking yourself off that medication, because you may develop withdrawal symptoms. So I cannot stress it enough. Make sure to let your provider know. Typically how the medications do work is there may be some improvement in the first 1 to 2 weeks. However, it does sometimes take 2 to 4 weeks for something to work, or sometimes even 2 to 3 months. So patience is key with these type of medications. And if there is no progress, let your provider know. Maybe they can adjust the dose. Maybe they can add something that augments it. Kind of the way I describe augmentation is like when you have a Wi-Fi signal in the house and it's not reaching to another, you know, part of the house. This medication kind of acts like that booster to help that medication or that signal work better in your house. Or sometimes they might actually just decide to replace the medication if it's really not working or there's really no response. Even when symptoms improve, you should talk to your provider and see if you could still continue taking it or if it is time to take yourself off of it. Because, what we are trying to prevent is any type of recurrent depression. And having another episode of depression does increase the risk of having another bout of depression. So healthy living is something to stress as well. Social support from family members as friends really does help patients overcome a major depressive disorder, as well as help prevent. And usually the social supports will encourage, they will aid in practicing any type of coping skills, as well as help with problem solving. Exercise is helpful as well. Jogging, walking, dancing, yoga, it could be used as a coping skill. It also helps in improving stress, sleep, as well as self-esteem. Eating healthy, vegetables, fruits, it kind of offsets the side effects of treatment. Drinking alcohol can worsen depression, disrupt sleep, as well as cause rebound anxiety. So, you're what you eat. So eating healthy is very important as well. Joining a support group, being social, get virtual help or ask provider for resources. One of a really great resource is the National Alliance on Mental Illness. All right, so now we progress into the topic of suicide. Hold on one second. Oh. Right, so I thought it was very important to include, data on suicide, specifically in New York. And suicide is a public health problem. It's a leading cause of death in the United States, and it can be prevented. More investment in suicide prevention, education, and research will prevent the untimely deaths of thousands of Americans each year. And this right here, this fact sheet is from 2019 data from the CDC. So in New York, it's the 12th leading cause of death. Second leading cause of death for ages 10 to 34. Fourth leading cause of death for ages 35 to 54. Ninth leading cause of death for ages 55 to 64. And the 18th for ages 65 and older. Just looking at these suicide death rates in comparison to nationally, we are 49 in state rank. 79.4% of the communities did not have enough mental health providers to serve residents in 2020. And over 6 times as many people died by suicide in 2019 than in alcohol-related motor vehicle accidents. 56.59% of firearm deaths were suicide, and 26.69% of all suicides were by firearms. So warning signs for suicide. So we like to kind of characterize these as immediate risk and serious risk. So for example, if someone's talking about wanting to die or to kill themselves, and they're actually starting to look ways on how to do that, whether, they're exploring it on the internet, maybe they're asking relatives, family, or friends. They're saying that they're really feeling hopeless. It seems like every time they're trying to problem solve, they don't see a way out of a situation. They can't even identify a reason to live, whether it's their own religious beliefs, if it's for family, if it's for work. They just can't seem to figure out what will cause them to want to live another day. Sometimes people will give away prized possessions or start to organize their life affairs. Some serious risk is individuals that start to withdraw or isolate, consider themselves a burden. Increasing in alcohol or drug use, or cigarette smoking. Typically this person would maybe have a drink once a week, and now it's like every day. Increase in risky behavior, not really caring how they drive, not really caring, what type of food they're eating, or really like just risky behavior, like buying, a gun or buying certain things. Extreme movability, like going from, being even in temperament and suddenly out of nowhere snapping to this irritable, angry person. Weight changes. Maybe the patient's not eating, or maybe they're eating a lot more. So some risk factors we look at as psychiatrists in order to determine the risk of a patient to attempt or complete suicide. So one is history of suicide attempts. Another is mental disorders, abuse of alcohol or substances, any chronic disease that a patient feels that it's intolerable to live with, having to care for their health conditions, a lack of social support, feeling that there's no one there to really help them, family history of any type of suicide attempt or completions, and any access to lethal means, guns, weapons, pills that are left over. Some precipitating factors: death of a loved one, serious medical complications or issues, end of a relationship or a marriage, an arrest, and any type of financial difficulties. And this list is, not, and it could be anything. Protective factors: people feeling connected to others, comprehensive behavioral health care, being connected with a therapist, a psychiatrist, a provider, like a primary care physician. Someone does have purpose or meaning to their life, whether it is, for their own beliefs, whether it is for, living for their family members, their pets, their job. Life skills or coping skills, being able to, feel this way, but still being able to cope through the emotion by either doing things that make them feel better. Like, some people do like meditation, some people like writing, some people like, watching maybe music videos or doing karaoke, things to kind of cope with what they're feeling and take them out of that moment. Cultural, religious, and personal beliefs. So what is very important, and what we try to do when we do find a patient that has like a severe high risk for suicide, we always try to reduce access to means of suicide. Especially when they have thoughts, they are, trying to work out a way to complete these thoughts. Perhaps they recently attempted. It is very important to remove all lethal means in the household. So that is locking up firearms, giving a key to a friend, storing firearms or giving it to a law enforcement. Family members should also store medication safely and dispense medications to individuals when necessary. Usually hospitals also do have places that you could come and dispose of excess medications. I believe at Mather it's in like the front, right? I think it's like around the front security. So there's ways of, and even if it's not at the hospital, you could just give it to your provider and they'd be able to dispose of it as well. Lastly, what we want to include is the National Suicide Hotline. So this number, 1-800-273-8255 or TALK. SAMHSA, spelled like SAMHSA, is also a really great resource to use online too if you're looking for healthcare providers that are within your area, whether it is just for mental health issues or if it's alcohol or substance related. It kind of provides you a list of places nearby. And also outpatient mental health resources here at Mather. The phone number is 631-928-3122. And it does lead to central scheduling in which they will direct you to either providers that do therapy as well as medications, or providers that just do medications only. And these are some of our references.
Thank you so much, Dr. Acito, Dr. Stanchek, and Dr. Taglienti for taking the time today to discuss such an important topic. If anybody does have any questions, please feel free to enter them in the Q&A. I do see we have a couple that we'll go through, but please feel free to keep going. We have a few minutes left. So how do I find help when every place I call says they're not taking new clients?
So sometimes help starts just even with your primary care providers. They can direct you to some resources they may know that is available. Another one is the SAMHSA. That one actually gives you a full list of like outpatient clinics that you could, try to see if they have anything that's close to you and is available. Also, some patients do call their insurance company and they could also provide like a list of resources. I don't know if there's any other ideas.
Yeah, if it ever gets to the point where, you don't feel safe, the best place to go would be to either call 911 or go to the emergency room, and then they have behavioral health providers there. They can also provide referrals to mental health clinics in the area, or, if you need to be admitted to the hospital, admit to the hospital.
There's also a service called Dash. If there's something that you feel like, you're having acute issues, you want to be evaluated psychiatrically by someone, they kind of are like, in a sense, like an urgent care for psychiatry. So that's also another outlet you could use. It's called Dash, DASH.
Great. What do you think about ketamine? I'm sorry if I'm butchering that.
So ketamine is a form of treatment. It could be used for many things. That is a medication that I would definitely discuss with a psychiatrist or provider and see if, you have, looked through every type of medication trial before engaging in ketamine treatment. I think that choice is, based on the individual and their treatment history and how they're doing currently in their treatment. But that is definitely something to have a discussion with your provider to see if you are a viable candidate for that. And if you've already, went through all different types of medication trials or therapy.
What if the negative toxicity around you is unremovable?
So that is definitely a difficult situation to be in, feeling that way, or, having experiences that prove your thoughts to be like that. I think during those times is, going into seeing a therapist and speaking about those situations, because sometimes we cannot change what is around us, but we can change how we perceive things and react to them. And that takes time to develop that skill and be able to work on that on a daily basis. But that is something I would recommend, is really speaking to like a therapist about it. And, trying to look at the situations and relationships and see what is leading to that emotion, and what is the best way to alleviate feeling that way.
Is there any data that suggests the cause of depression and suicide thoughts?
So, I mean, some data, I think it's very hard in terms of, psychiatry of, it's not like medicine that we can just take blood work and really figure out what is going on. There have been some relationships shown with neurochemical imbalances that we've been talking about with serotonin and norepinephrine. And it seems to be like once we target those chemicals, patients do feel better. So it does come to make us feel that this is something that is actually working on that type of mechanism to help improve patient symptoms. I don't know if there's, yeah, another thing is genetics. So looking at genetics, that's why we always, when we do a psychiatric evaluation, is asking if there is any family history. Another thing we usually do ask is seeing if there is present family history, if there's a certain medication a family member is taking, because it does end up working on that patient who's, seeking a medication.
A psychiatrist has noted that focusing on small screens, like sitting in front of a computer for hours long, especially at work, may be a factor for developing depression. Is this supported by clinical data?
Not that we're aware of, but it's something I'll definitely, look into. Yeah. Because I think right now with the Zoom culture and us being, due to COVID being in front of our computer a lot, that would be an interesting study to look into.
Does Mather have a psychologist department?
So we have psychiatrists. So I guess one thing to emphasize is the difference between psychologist and psychiatrist. So psychiatrists, finish undergrad, they go into medical school, which is 4 years, and then they take up a residency, kind of like you have a choice of going into OB-GYN, you have a choice of going into surgery, internal medicine. Us as, psychiatrists, we choose to go into residency for psychiatry to become psychiatrist. Psychologists work a little bit differently. They go do undergrad and then they also end up doing, I guess, like work undergrad and like
a PhD program, usually.
a master's.
Yeah. So we don't have specifically a psychology department, but we do have, the psychiatry residency. We have our psychiatry clinic. We have a psychiatry unit. So hopefully that answers your question.
Maybe the mental health clinic does the therapy part, so explain.
Yeah.
Sure. So at our mental health clinic, we do have, both psychiatrists and then we have therapists who are primarily social workers, so not specifically psychologists, but they do get, their master's in clinical social work. And so they're very experienced therapists. And so if you were to come to our resident clinic, you would see both a psychiatrist and a therapist. So you get both the medication piece and the therapy piece.
Does verbal abuse contribute to depression?
It definitely could be a factor. Any emotional, physical, sexual abuse can definitely, be a precipitating factor.
Does depression have a social component in the sense that social environment can affect your depression?
Yeah, so that's one of the, factors that we did actually talk about in the presentation, that, along with genetics, along with biochemistry, that like the environment also does play a factor. So, with, therapy, you can, develop tools to better like react to your environment or learn, how can I remove myself from this situation, things like that.
How effective is Prozac? Is there any new modern developments in the medication field?
So Prozac is one of the oldest like SSRIs that we know. So we know a lot about that medication. Patients that, every patient's different in terms of how they react with medication. So sometimes it is kind of, trying to figure out what medications fits your puzzle in a sense. But it is a really great medication. There are, newer ones like, there's Zoloft, there's Trintellix. There's definitely an assortment of medications. I would definitely speak to your provider in seeing, what would work best for you.
What do you recommend for patients when your psychotherapist and psychiatrist don't communicate with each other?
Bring it, speak about it. Sometimes it's when you come into an office and we can't mind read. Sometimes it's important to actually say, hey, this is how I feel. I feel that no one's communicating, and give them an example of it. I think it's important to have a very honest relationship with both your therapist as well as psychiatrist. And hopefully that will open further a discussion.
What are the side effects of using ketamine therapy, and how effective is it if it's your treatment?
It's a newer treatment option, so the evidence is still evolving on the ketamine, which is why we tend to use it as a last resort after all of these medications, which have been around for a long time. And we know a lot, there's a lot of evidence, we know a lot about them. One of those is Prozac, for example, it's been around since the early 80s. We try to go with those more traditional FDA approved medications first, before going off to the ketamine, just because the evidence is still evolving. There is evidence for it. There's the IV ketamine infusions that you would have to set up, through like an ambulatory setting or a surgical setting. And there's also the newer nasal ketamine, S-ketamine, but that can only be prescribed by certain practitioners with special type of license, and it's a very, very controlled substance. So they do work for some people, and there's definitely evidence behind them, but they're newer treatments, so we don't know as much about them as we do some of our traditional meds. So we go with the traditional meds first, and then if they don't work, we might recommend ketamine. As far as side effects go, you can have issues with your memory, short-term memory loss and things like that, but they're usually short-term type of side effects.
Great. Could you give us examples again of what support groups that are available? I think they might have missed that the first time around.
So at our clinic specifically, we have a lot of different groups, group therapy that we do. So we have like a mindfulness group, we have like a wellness group, we have a healthy living group, we have a CBT group. So that's like a specifically focused on like cognitive behavioral therapy. And we have like an adolescent group, and then there's groups in the community too as well, right?
Yeah, but with the clinic, you have to be enrolled as a patient doing both the seeing a psychiatrist and an individual therapist to be able to come to those groups. There's other groups that you could probably find on the SAMHSA website, SAMSHA. If you Google that, there's a lot of like bereavement groups, for example, and other specific type of topic groups that are out there in the community.
Okay. Is it depression if you can't control your emotions, as in even though you're happy, but you think you're happy, but you still break out in tears?
So just based on that statement, it is very hard to label that as being depression. I definitely would say for that individual to, seek out like a primary care physician and really describe more about the symptoms. To see, if there's a certain stressor that may be causing that, if there are other symptoms like lack of interest in things, to really give a formal diagnosis. Because that might be, irritability may be a symptom of it, but, seeing everything in its whole and doing a comprehensive interview would be very important to find out what the diagnosis would be.
Okay, great. We have a bunch of thank yous in here. What makes MDD different from seasonal depression?
So seasonal depression, it says it in the word. It comes during specific times of the year, whether it is, the start of fall, being in the winter. People specifically notice throughout the years, that's when their depression gets worse. Major depressive disorder, sometimes there can be like a specifier to having a major depressive disorder with having like a seasonal type of pattern. But major depressive disorder is pretty much like having that like a lack of interest in feeling depressed more than 2 weeks, with having 5 out of those 9 symptoms that we talked about before. And it could be specified with the seasonal pattern.
What is the difference of a clinical psychologist and psychiatrist, which I actually think you just covered, so we'll pass that one. How can I get more information on the clinics? Would that be to call the central scheduling number? I can put that back on the screen for sure.
Yes, you could call the central scheduling number. And I do believe if you type in on the internet, like Mather Health Clinic, information on that can pop up as well.
Yeah, anybody with any specific personal questions, we would urge you to call that number where you could be advised further along. One more question here. What can others do when they see a loved one that might portray certain symptoms that may suggest depression and or anxiety?
I would say talk to that individual, have a very honest and open conversation and tell them that you're there to support them. I think even hearing that just speaks volumes. If you know of resources, you could, present them to the person. But, have a conversation, open that door.
For the support groups, do you have to see a Mather psychotherapist and or psychiatrist, or can you just participate in a group talk?
So at the Mather Mental Health Clinic, you would have to you become initially screened as a patient, and then eventually, if you are accepted into the clinic, you have to see a psychiatrist as well as a therapist. And then based on interactions with, collaboration of care with the psychiatrist and therapist, we discuss, if group therapy, including the patient, is an additional helpful form of treatment for the patient. But groups exist outside of the mental health clinic, Mather Mental Health Clinic. As I said, like there are groups out in the community, and utilizing the website that Dr. Teglianti just mentioned, like the SAMHSA, will help you locate those places that also offer just groups and don't really offer, the psychiatrist with the therapist at the clinic. So if you're looking just for like a group, definitely, utilize that website, or just look online and see if there's anything available near you.
What medication is mostly effective for SAD?
Yes. So one thing that's, not medication related would actually be like light therapy. So there, you would use light in the morning for like a certain amount of time that could help, even just improve your mood, with the seasonal changes with the light. But, if we're looking at a medication, we would typically try either an SSRI, so that would be something like Prozac or Zoloft, or possibly something like Wellbutrin that works on norepinephrine and dopamine.
But I would also speak to a provider as well, because you can't just buy any type of phototherapy box. There's specific type of magnitude you would need with a phototherapy box, an appropriate amount of distance. You don't need to stare at it, and for how long you would need to use it, typically around 30 minutes. But I would definitely, speak with your provider to see what are the best, phototherapy light boxes around, because you don't want to be using a light box that's not going to do anything because the magnitude of it is inaccurate. So I would definitely speak to them about that.
Does MDD have a higher risk for personality disorders or vice versa?
Compared to like just general population, yes.
How would you define if you need a clinical psychologist or a psychiatrist?
I think typically patients do see, like, I think it's just starting out to find whatever is available first. And sometimes when you see a psychologist and they realize that with therapy and coming in that you do need medications or more treatment, they may recommend a psychiatrist. Or even when you see a psychiatrist and we're working on medications and still there's just certain aspects that are not being addressed that would be appropriate for therapy, they themselves would recommend it. So I think it doesn't matter which one you start out first. I think either way they will, the professionals will recommend what is suitable in your case.
Does a licensed social worker serve to provide those therapies?
Yes.
Yeah.
And certain one of them do specific types of therapies. So that's something maybe you might want to ask your therapist of what kind of therapy do they like to practice? Cognitive behavioral therapy, mindfulness.
Great. And there was just one more. Somebody was requesting a phone call. I don't believe we're able to just give you guys a call. You would have to call central scheduling first and then leave your information. And if they could talk to you then, or you guys could get a call back. I believe that's how it works, right?
Yeah. And another thing I like to add about a question a little bit earlier on, like major depressive disorder as well as personality disorders are very, important things to seek treatment for, regardless of what you're diagnosed with. I think sometimes we really focus on diagnosis, but at the end of the day, as a psychiatrist, we look at symptoms. We look at symptoms and trying to treat what the symptoms are.
Great. Thank you all so much for taking the time today to present on such an important topic. The number is on your screen if you'd like to call Mathers Outpatient Mental Health Resources. We also have the National Suicide Hotline on here for you guys. Everybody, please enjoy the rest of your day. You'll be getting an email with the slides from today for your reference, and also a link to complete a survey just on how the speakers did today and how the webinar experience was. Thank you again for attending, and everybody enjoy the rest of your day.
Bye.
Thank you.